Fantastic. Thank you all so very much for joining us today. Welcome to the GROW.V.BABY Research Network Roundtable. GROW.V.BABY stands for Group Wellness Visits for Babies and Families Research Network. And we're so excited to kick off 2026 with this really special first research seminar. On behalf of Dr. Claire Viglione and myself, Renee Boynton-Jarrett, the Vital Village Networks team, and the GROW.V.BABY Research Network, we're really delighted to welcome you here today. We'd love to have our chat getting us to know each other a little bit better. It's great to see old and new friends and members of the village throughout. But please feel free to add your name, your organization, what brought you here today, and it would be wonderful to just see the chat light up with a little bit about who we are and where we're from. Feel free to put in the state or city that you're also logging in from. So feel free to add to the chat if that is available. Hopefully everyone can access the chat. Wonderful. Thank you. Welcome, Ellie, one of our GROW.V.BABY steering committee members. Welcome, Marisol, one of our villagers and former member of our team. Welcome, Tyson, Ken, welcome, Faith. Oh, wonderful. Welcome, Helena. It's so great to see everyone from everywhere here today. Thank you for joining us. We'll continue to do more incredible welcomes. Wonderful. Oh, so great to see everyone here. Just to tell you a little bit about the GROW.V.BABY network, and we'll be sharing ways to continue to get involved. There are two levels of membership: a general network membership level where you receive newsletters, updates, invitations to wonderful research meetings and presentations such as this one, opportunities for webinars, trainings, peer support, and the opportunity to also participate in network-wide research initiatives and evaluation and community-based participatory research work. There's also the investigator membership level where you'd be PI or co-investigator, really helping to draft proposals, manuscripts, forging and creating research questions that the network would pursue together. So just to share a little bit about ways to get more involved, and if you'd like to hear more about it or register, feel free to use the QR code that's listed here to sign up. And I think there is also a Google link that I can paste in the chat. Oh, Claire has already done so. Wonderful, it's there. Just to share some save the dates and things that are coming up, we'll be having the steering committee meeting in about a month in April. In May, we're going to be having some pilot project discussions. We'll have our next research roundtable seminar featuring Dr. Arvind Garg in June, steering committee in July, and then October 22nd through 24th, we'll have the National Community Leadership Summit, and October 22nd will be a full day relational health group care leadership workshop. So very excited about these upcoming events on the calendar, and we really hope that you'll be able to join us and participate, share, and we'd be excited to learn alongside you. So now I have the distinct honor of getting to the meat and potatoes of why we're all here. But Dr. Cynthia Osborne is so much more than what can be shared through this bio. As the Executive Director of the Prenatal-to-3 Policy Impact Center, we're so excited. I'm sure there are many people in the room who are familiar with the Policy Impact Center, but if not, we're really excited for you to learn more about this incredible resource that's really helping to support and drive systemic policy change across the country. Dr. Osborne is a professor of early childhood education and policy in the Department of Leadership, Policy, and Organizations at Vanderbilt University's Peabody College. Now that a member of my family, my oldest daughter is a Vandy member of Vandy grad school, I'm feeling even more connected. She's the founder and executive director of the National Prenatal-to-3 Policy Impact Center, which is an academic research center that translates the science of the developing child into state-level policies with the strongest evidence base of effectiveness. Many other accolades and awards that Dr. Osborne has, and I am so excited to turn the floor over to Dr. Osborne for our conversation today. So I will stop screen sharing and open up the floor for our guest.
Well, thank you. Thank you very much for the opportunity to be here and to share more with this network. And I was really excited to learn more about the network. I've worked with Renee on some projects before, and to have the opportunity to really see how this network is growing, and just how important it is. I'm really glad to be a part of it today. I have some slides that I'm going to share, and although I could talk for hours and hours, I really want to have a conversation with you and about um, how some of these resources might be helpful to you, the things that maybe we don't have that would be helpful. But today I wanted to share with you more about what our center does and why we exist, and the resources that we want to provide to researchers and policymakers, practitioners, advocates, and so forth. So we are a research center. We're nonpartisan and are not advocates, although we share a common goal with many about wanting all children to thrive from the start. And our approach was to turn to the evidence and to ask what we know from the most rigorous evidence available about what states can do, what their role is in creating the conditions in which children will thrive. And all of our work stems from the science of the developing child. Each of you is probably very familiar with this body of work. But when we stepped into this space in 2019, what we saw was that across the country, more and more policymakers and experts were understanding that the first 3 years of life are the most rapid and sensitive period of development, and really do lay the foundation for all subsequent health and well-being. And that the key to that healthy development is that our children are exposed to safe and stable and stimulating environments that have these nurturing interactions between child and caregiver, as well as limited exposure to adversity. Um, so as that body of knowledge was developing, and folks were quoting, the percentage of the brain that's developed and the number of neural connections per second and so forth, um, what we also saw was that there's still huge disparities in the number of children who are exposed to these conditions that we know are so important for lifelong health. And we wanted to step into the space and say, well, if these are the conditions that children need, then what is it that states can do to really help to create those conditions? So we started by operationalizing this science into these policy goals to make it clear what it is we're aiming to do. And as I mentioned earlier, we're not at all neutral to these goals. We are not advocates, but we are driven by the science. And the science tells us that if we could create these conditions, if we could meet these goals, that our children and families would be thriving. And so it means that families have access to the services that they need and that they're eligible for, that our parents have the ability to both work as well as care for themselves and their children, that children and adults live in households with sufficient resources, and we think about food security, housing stability, as well as economic security, that our babies are born healthy to healthy parents. And we think about both the physical as well as the mental health of the family, and that our parents really understand and have the knowledge and skills and capacity and time to engage in those nurturing interactions that we know are so important for healthy child development. And obviously, that's where this network really plays such a huge role. And that when our babies are not with their parents, in childcare settings or in home visiting environments or other situations, that they're also engaging in these nurturing relationships, and that our children have access to the types of supports that they need early on. So, if parents are going to breastfeed, that this is a possibility, that our children are immunized on track, and that we can identify developmental delays as soon as possible, get them the interventions that they need, and get them back on track for optimal development. So, again, this is what the science tells us kids and families need in order to thrive. And our approach then was to say, well, again, if this is what they need, what are the policies that can help to shape those environments? And we turned to the existing evidence base and reviewed thousands and thousands of papers that have been written, and really focused on those studies that were able to show a causal link between the policy or program at scale and improved outcomes on at least one of those 8 policy goals. And kind of the 4 big takeaways from all of this research that we did on policy were, first of all, there are things that work. We continue to add to that list of effective policies, but so far we've identified 17 that really show this evidence that they will make a difference in at least one of those policy goals. And I'm going to share more of that with you today. But there's no policy or program out there that will only help the child. That our children, especially in those earliest years, don't exist in isolation. They exist as part of their family. And so what our policies have to really take into consideration is that we need to care for the caregivers so that they can do the job of caring for their children. And often in situations in which folks are excited to, help children, they think they're cute and cuddly and that they deserve an opportunity. But often they're a little resentful of their parents. Why did they have them if they can't afford them? The parents aren't making good choices. And the truth is that sort of thinking doesn't actually help children, and they're a unit, and we have to make it so that the caregivers, including childcare educators, home visitors, pediatricians, and others, can actually do the job that they set out to do. The other major finding, which is not a surprise to any of you, I know, but is that there isn't a silver bullet. There's no kind of magical program that is going to do it all. And I often get asked, what is the thing that we should do? And the truth is that in order to really create those conditions in which children thrive, that it requires us developing a system of support, of broad-based economic and family supports, as well as more targeted interventions that center the family and really see it as the system. And not only did we identify which policies are effective based on the most rigorous evidence that's available, we also have been monitoring what states have been doing to implement these effective policies. And one of the things I'm going to share with you today is that the variation across the country in the implementation of these policies, in the generosity and the reach of policies across states is just huge. And that there's really a patchwork of benefits and services available to families. Our center is really built around 4 pillars. And we have teams that represent these and different products and initiatives within each. And I'm just going to go through them briefly and spend more time on some of these effective policies and showing you how they intersect. But for those of you who are researchers or interested in learning more about our center, I just wanted to walk through what these four pillars are. So they include building the evidence base that we are constantly looking to see if there are new policies that we can add to our annual roadmap. And we do original research, original policy, program evaluation. We do studies to see when states implement policies, what those impacts are. And we've created a database of all of these policy changes or policy tracking system that we want researchers to use who are interested in doing policy evaluation. Our second pillar is identifying what works. And here we focus on existing research, and I will share with you some of the resources here. We have a clearinghouse in which we go through what the evidence is for each of the policies that we've reviewed. We have an annual roadmap in which we put the policies that have an evidence base of effectiveness on this and track what states are doing toward implementing those. And we have a new series in social policy history that really helps us to understand how we got here and what our histories have done intentionally to lead us to a place in which our policies are often inadequate and very inequitable in their distribution. Our fourth pillar is tracking state progress, and we do this right now. We're deep in it because we're in legislative session. We look at every state in DC and review any bill that is related to one of our policies or kind of policy adjacent areas. We also, the most common question that I'm asked across the country is, what are other states doing in X, Y, or Z, childcare, perinatal health, what have you? And so we have lots of resources in which we are showing what's happening across the country. And we have another initiative that focuses on states' early childhood governance structures and how these are changing and evolving over time to better meet the needs of families within states. And finally, our fourth pillar is really on shaping policy development. We're educators, we're not advocates, but we are experts in data and analysis and have lots and lots and lots of data to share. And so I'll show you some of the resources that we create, like benefit cost analyses, various policy analyses, cost modeling, as well as a policy impact calculator that I'm excited to share with you. Just a couple of examples of work that we're doing in North Texas, for instance. We did a scan of the supply and demand for childcare and some of the constraints that they have to finding enough educators to fill their childcare slots, and working with them on a long-range strategic plan to try to build their educator workforce. We're doing some evaluations both in Nashville, in Connecticut, and other places of Family Bridge's Family Connects model, so or a comprehensive screening connection program. Begin Bright is a shared book reading model, and Raising Readers is another landscape study of childcare supply and demand. And then I would love to spend the whole time talking to you about our policy tracking system. Right now, the policies we have are, kind of range for all of the ones that are in the roadmap, or nearly all of them in the roadmap. We're focused largely on trying to build the evidence based on paid family medical leave because most of the research that's been done on that policy has just looked at whether a state has it or not, but not the duration or the generosity of it. And so we have thousands of data points for researchers to be able to use to really make the evidence base more rigorous. So I want to spend some time on identifying what works and make sure that you're aware of our Prenatal-to-3 Policy Clearinghouse. And I know I have some colleagues on the call who can put in the chat the link to this. Um, but these are comprehensive reviews of every policy that we can get our hands on that has been looked at in any way. And right now we have labeled them either effective or needs further study, meaning that it either hasn't been studied really hardly at all, or any of the research that has been done hasn't risen to the level of rigor that is needed to make a causal inference between the policy or program at scale and one of our outcomes. Um, and but this list is growing annually. We're trying to add more on housing. We're adding more on child maltreatment policies, medical legal partnerships, and so forth. So, um, we're open to any suggestions you have of ones that we could review. And also, I mentioned our social policy histories. I also invite you to share these. And for any of you who teach, these are a really great resource for students to understand our history, to understand how we got here to a place in which we are the wealthiest nation on the planet and have the fewest resources to provide to parents with new children when it comes to family care policies. Um, we also have this annual roadmap, and I'm going to spend more time on this probably than some of the others. But this this grid that you see is really our roadmap. Across the top, those 8 circles are those policy goals that I started with. Those are the science, what the science tells us we're working toward. And along the left-hand column are the effective policies and strategies that we have been able to identify. And we show how these align. And there's no policy that affects each of those goals. And, there's no goal in which every policy is going to solve it. But you can see that there's some areas that are much more robust and widespread, and others that are much more targeted. We also create a roadmap for every state as well as DC so that they can really see how their state is doing and the areas of opportunity for growth within their state. And one of the things I mentioned earlier that I think is just so important is what we're really focused on, rather than a grid, is really this system of care that centers the family and thinks about these comprehensive needs that families have. And there are now 17 of these policies and strategies that we've identified as effective. And they can often be grouped into things like early care and learning, or parent and child health, economic and family supports. And on the call, many of you probably identify with one of those areas more strongly than other areas. And that's just the nature of research and siloed implementation and so forth. But what we try to kind of point out here is that there's a lot more overlap than it might kind of appear at first glance. That, um, you know, for our child and parent health, one of the most effective policies at improving birth outcomes for our babies is a higher minimum wage. And that's often, thought of as an economic policy, but that's also a health policy. Similarly, one of the most robust policies we have to reduce families entering into poverty is expanding Medicaid. And also the, child care subsidies are a policy that allows families to work. And so if you think of yourself as an economic and family support policy, you may want to look to your health and early learning colleagues for support on some of those. And as well as early care and learning, We know that programs like doulas really enhance parents' ability to interact and care for their children, which promotes early learning. And so those are just different examples of how these systems really are not siloed from the impacts that they have on families, and that we hope that our states and communities start to break down silos as well. And when we think about the roadmap, you can really enter it either through your goal or your policy. So when we work with states, they may come to us and say, the chair of the Women's Caucus in Mississippi came to us after the passage of Dobbs and said, we need to improve birth outcomes in our state. How do we make sure our babies are healthy? So we were able to start to work with them on the types of policies and strategies that might lead to better birth outcomes. Similarly, Pennsylvania comes to us and says, we're interested in introducing a paid family medical leave program in the state, and we want to kind of learn more about it. And we work with them to really help them understand what it is, how states are operating it, what the impacts are, and so forth. Um, in the roadmap, we also show states how they're doing on a series of various outcome measures. And this will allow states to prioritize maybe where they need to dig in. Massachusetts is an example of a state that, by and large, is above average on all the outcomes that we have on our roadmap. Um, but there would be areas to start to focus on in which you can, when your state is kind of over to the left of center, to say that is something that, we know we can do better. Even when you're at the very, very far right in the top, that doesn't mean that everyone in your state is doing well. Reading is a perfect example. In the best state still, nearly 40% of babies and toddlers are not read to daily. So that's another way then you could look to see what are the policies and strategies that align with those goals. And for our strategies, um, we have a series of policy levers that our research and our experts have told us these are the types of things that will help to improve and increase access to these sorts of effective strategies. Conversely, our policies, the research guides us on what threshold is needed in order to actually see the impacts in the research. Um, so the number of weeks necessary for paid family medical leave, a minimum wage that needs to be at least $10, or earned income tax credit that needs to be refundable in at least 10%. On those, we can give states check marks and say, you've done this. Whereas for our strategies, it's more that you're making progress toward this and wanting to fill in all those dots. So I also wanted to show you how states vary in implementing their evidence-based policies. I mentioned at the beginning that variation across states is huge, and um, one of the kind of biggest findings I feel from all the work that we've done is how families vary in what resources they have available to them based on the state in which they have their children. So Medicaid expansion, this is one of our policies on the list. I don't have to convince you all, I'm sure, of its importance. And there are still 10 states, though, that have not expanded Medicaid. Montana made progress last year in making its expansion permanent. Um, but, although there's activity, most of these 10 states are probably not going to expand it. And then right now, we're actually watching that states don't unravel their expansion based on the new developments at the federal level. We have these sorts of resources for each of the policies and strategies on the roadmap. I'm just showing you some examples of the types of information that's provided. Um, and this is a illustration of some of the variability in Medicaid income eligibility. This is for parents. And so my old state, I was at University of Texas at Austin for 17 years. And in Texas, parents have to make less than 15% of the federal poverty level in order to qualify for Medicaid. They haven't expanded the program. In Tennessee, they haven't expanded Medicaid and are doing it the expensive way, but you can have incomes up to 105%. And you can see the states that have expanded Medicaid. Um, we are excited that Wisconsin just extended their Medicaid postpartum to 12 months, which is leaving Arkansas the only state that hasn't done this. We're waiting for Wisconsin's to go into effect, but this is a big change just recently. Another one of the policy or strategies on the roadmap are comprehensive screening and connection programs. And these are programs like Family Connects, Healthy Steps, Dolce, in which they're universally provided to anyone born in the hospital or at the pediatric practice. And they focus a lot on screening both the parents and child, and then providing the types of services that they actually need based on those screens. And when we look across the country at the states that have done things to try to expand access by setting goals or using Medicaid to fund or state funding, you can see that there's a range across the country and who does what. Um, in group prenatal care, I know that you are all familiar with this. By the way, we cannot wait to get results for the Centering Parenting so that we could add that to the roadmap as well. But the policy lever at the state that we have found that is really how states can enable the expansion of group prenatal care is to enhance the Medicaid reimbursement rate for it. Others are funding pilots or scale ups and so forth. But even among those states that are offering an enhanced reimbursement rate, you can see that there's a lot of variation across the country in the amount, whether it's per visit, per person. It ranges from $7 in New Jersey to $50 in Louisiana and in Maryland. And the reach of the program and how many sites there are varies. Again, the whole story of the roadmap is variation. Community-based doulas are another of our programs. And again, these are ones that really do home in on that perinatal period. And our community-based doulas, I would say, of all the programs and that we have here, they have shown the kind of biggest expansion over the past several years. This is since 2020, you can see the number of states that now allow Medicaid to fund doula services. There are 7 additional states that are set to do this in the next several years. But again, just because those states allow Medicaid to reimburse for coverage, Medicaid, the amount varies substantially. So in Washington, now they're the state with the largest reimbursement rate of $3,500. New Mexico and California follow that, as well as Minnesota. Whereas you can see in Virginia and Maryland, it's less than $1,000 per doula. And also the types of services that are covered, the number of visits and so forth, all vary quite considerably. And we have all that information in the roadmap. Our home visiting services is another area that many states are using their own funds or Medicaid funding to fund home visiting. And that leads to a wide range in the proportion of eligible families that actually get access to home visiting services. It's over a quarter of families in Kansas and fewer than 2% in several states. Our early intervention, again, is just another example of a policy that helps children in our earliest years. You're all very familiar with it. And there are some things that states can do to make it so that more children will have access to these that might need them, whether it's kind of making these qualifiers for um, automatic qualification or reducing family fees and so forth. And Massachusetts is a state that serves the most number of children, the largest number of children. 20% of kids are served by EI in Massachusetts, and the majority of this is because they have used Medicaid funds so effectively to do this. And, whereas fewer than or 3% of kids in Arkansas are served by EI. All right, in the interest of time, I'm going to move through a little bit faster, but I really, for this audience, I think the roadmap provides some valuable lessons in that we know that there are some really effective things that can help children and parents in its earliest years, and in particular in that perinatal period. And I'm kind of excited about how states are using the new postpartum Medicaid extension that allows coverage for 1 year to try to provide more postpartum care. Who is owning these moms during this time, and how are systems coordinating? I think there's a lot of room for learning and in that space. So the last way that we track what states are doing is we put out a weekly legislative trends newsletter. It just came out today. And I invite you to sign up for it, and you can find out what every state is doing and maybe even learn what your state is doing. I also invite you to see our resources on early childhood governance. What we were seeing is that more and more states were starting to create their own departments of early childhood. And others were asking questions about, well, how do I coordinate my services better? And so we made these organizational charts for every state in DC, and this allows practitioners, families, advocates, elected officials, even state level administrators to really understand how their states are laid out. And what we find is that states organize themselves based on different sets of goals. So some states for early childhood really just want to focus on school readiness, and they'll combine all of their pre-K and child care and Head Start and maybe even home visiting into one department. We have others that really want to focus on workforce and work support. So that's your SNAP and TANF and child care all kind of in one place. And then we have others that are more holistic in thinking about the whole child and really elevating early childhood as high as K-12 and health and higher ed and so forth. In our shaping policy development, some of the tools that we use with states include these benefit cost analyses. What I find in talking with elected officials and advocates is that they often want to know, well, how much does it cost? How are we going to pay for it? Is there any return on that investment? And so because our research relies on causal evidence, we're able to use that evidence then to apply that to state level data and be able to put a dollar amount to some of those savings. So, for instance, doulas reduce it postpartum neonatal infant mortality, excuse me, and by 12%. So we're able then to go into a state and look at the number of babies who die between 30 days and 1 year and reduce that by 12% and say these are the number of children who will not die. And this is the cost savings or avoidance to the state because of that. And We're able to do it for the state, for families, for employers, and so forth. In the interest of time, I'm going to not spend a lot of time on that, but we've done this for nearly a dozen states now. And depending on how the programs set up their paid family medical leave programs, or in this case, this is what the policy we're looking at, um, and some of their state level demographics, the returns can be, widely variable. One of the things I want to make sure that you're aware of is our policy impact calculator. So our policy impact calculator is newly interactive. We've been using this tool for a while, but now we've created a version that you can go and kind of operate it yourself to tell the story of Lena. And Lena is a stylized mom who is a single mom who has an infant and a toddler. And Lena works full time all year round. She doesn't take one day for vacation. She doesn't take 1 hour of sick leave. And she works at a state's minimum wage job, though. She did just have her baby, and so she took 12 weeks of leave that's available to her based on the Federal Family Medical Leave Act, or FMLA. She's one of the 56% of employees nationwide that are eligible for that. If she lives in a state that offers a statewide program, then she gets those benefits during her leave. Um, and unlike a lot of moms, Lena applies for and receives everything that she's eligible for. Um, that includes her child care subsidies and so forth. And she also files her taxes, so she gets all of her tax credits back. And in order to work, she sends her children to child care. And she sends them to care that charges what the federal government calls the equal access target. That's the 75th percentile of a state's market rate. I can go into that in questions if you're interested to know more. But this way we can compare Lena across every state to see what is the difference in Lena's resources based on that state's policy choices. So we look at the policy choices related to her earnings from a minimum wage job, whether they have a protection of those earnings based on family and medical leave, their out-of-pocket child care expenses, the subsidies for child care. Then we add in the federal nutrition benefits and taxes and tax credits, as well as any state taxes and tax credits. And as just kind of a highlight here, where Lena lives matters. State policy choices make a very big difference. If Lena has her children in Colorado, the minimal level of resources she has available to her is over $56,000. Whereas if she has them in North Carolina, it's less than $21,000. And you can see Massachusetts is kind of in the top 10 there. And let me walk you through what some of kind of how those variations come about. Let's look at Massachusetts and how Lena in Massachusetts would have around $47,000 at a minimum in resources to prepare for her children if she was our stylized mom. So we start with a minimum wage job, and in Massachusetts, that would mean that she's earning $15 an hour, which is over $31,000 a year. Again, she doesn't take one day off. But she does have her baby, and so that means that she loses 12 weeks of leave if it's unpaid. That's what our Family Medical Leave Act earnings look like. Or policy looks like. So that means she loses around $6,000 in earnings. In Massachusetts, though, you have a paid family medical leave program statewide. She has paid into this program, and now she's able to reap the benefits. And that protects around $5,700 of her earnings. Remember, she paid into that already. Those are her earnings that is being protected. She does have to send her children to childcare in order to work. And in Massachusetts, it would cost her over $42,000 a year for her to send her infant and toddler to childcare. And that means that Lena would have to spend all $29,000 that she earns and come up with another $13,000 somehow to beg, borrow, and steal to pay childcare. Well, Lena's not going to do that. None of us would do that. We couldn't afford to spend every dime we make and borrow more just to send our children to childcare that is allowing us to work. That math doesn't math. In Massachusetts, however, she has access to a child care subsidy that protects most of those earnings. And so rather than that 42,000, she's only paying around $300 in out-of-pocket child care expenses. In addition, she has access to her federal nutrition benefits and federal tax credits, and that adds another close to $14,000 or more to her resources. And in Massachusetts, she also has a state earned income tax credit as well as a state child tax credit, and that puts her up another $2,300. So for each state, you can walk through what Lena's story would look like and how you end up with that level of resources. You can also look and see how Lena's life changes based on the year in which she has her kids. And so this is not within family over time. This is if she existed in 2020, 2021, and so forth. Well, in Massachusetts, Lena may have been smarter to wait to have her kids because today she has 11,000 more in resources than she would have just in 2020. And that comes from the introduction of paid family medical leave, as well as an expansion in the earned income tax credit and the child tax credit. There are some federal changes, obviously, that have taken place, and the SNAP is more generous, or child tax credit is less generous in 2021. But you can really see how these state policy changes made a big difference in Lena's life. You can also look to see how your state compares to other states. And some states, in some states, this is very motivating that, well, if they can do that, why can't we do that? Again, I lived in Texas forever and it thinks itself as a country, so it's not really motivated by this so much. But these comparisons can be fruitful. And they can help you to see what it is that's driving the differences. So in Maryland, the red to the left there are Lena's out-of-pocket childcare expenses. That what's happened is that the market rate, the cost of childcare has gone up much faster than the reimbursement rates that providers get. And that leaves families with a lot of out-of-pocket costs to cover. And you can also see the navy is a difference in wages. And so minimum wage can create a huge difference in addition to paid family medical leave, the light blue, and then the blues on the end for the state tax credits. We also allow your state to model what would happen to Lena if you implemented new policies, new roadmap policies. Massachusetts has all the roadmap policies, so we're using Pennsylvania, we're picking on them. But what if they were to increase their minimum wage to $10 an hour? And we can work with you to answer the questions, well, how many people would that impact? What if we offered a paid family medical leave program? That's going to help Lena quite a bit in the year she has her child. What if we offered a generous earned income tax credit? That's going to help Lena every year. What about a child tax credit and so forth? And so it can really help those who are trying to advocate for policy change see what the impact would actually be on a household. We can also use the calculator to show how resources within a state vary based on income. Most of you are familiar with the concept of benefits cliffs, and this means that you earn $1, but you lose more in your benefits than you actually earned through higher wages. And that often makes it so families are a little apprehensive about moving up. And you can see that in Massachusetts, that's a real fact for many families. If you look there at $20 an hour versus $30 an hour, well, that's $20,000 a year additional earnings at $10 an hour, 2,000 hours, $20,000. But you can see that Lena's total resources at $20 an hour are actually slightly higher than they are at $30 an hour. She has to pay more out-of-pocket childcare expenses, and she loses all of her SNAP and WIC benefits. She loses nearly all of her tax credits and pays more in taxes. So for her, it just doesn't actually pay to make a lot more. And states are trying to grapple with this conundrum that if families are going to be self-sufficient, we have to make it so that earning more doesn't mean that they're worse off. Um, I invite you to check out the calculator and do all sorts of fun things with it. I'm not leaving a lot of time, so I'm not going to wrap up here, but or not spend time here. I'd rather answer your questions. But my goal was to introduce you to the types of resources that we have available so that you could really start to understand what the evidence-based policies are and which states are implementing them, the impacts that they can have, and some of the tools that we may be able to help you or your state with as you look to implement more effective policies. So I'll stop there and open it up for any questions or look in the chat for questions as well.
Thank you so much, Dr. Osborne. That was really, my mind was blown a couple of times during your remarks and seeing just the incredible consistent pattern of such wide variation across states really, feels like a place, right? And I hope you're seeing the wonderful reactions in the chat. There is a question around the slide deck, whether or not it will be available. And I would invite if anyone has a question, please. I see Tyson's hand is raised. Tyson, if you want to squeeze in a question, please go for it.
Yeah, hi Cynthia. It's good to see you. I'm curious what research and work you've done around, given it's like been in the news, like universal basic income, and also can you speak a little bit? It's like there's a lot of mixed findings around that from the baby's first year studying the RCT. So
Yes.
there's like one a little bit of that, and then part two is, do you see differences on the RCTs and the quasi-experimental designs, and like how does that pan out in some of these policy questions?
It's a great question. So, we are actually adding cash transfers and these sorts of to the roadmap. And with some, in our clearinghouse, we're very clear that there are mixed findings on some of the outcomes. And even with baby's first years, there's some positive findings that we think are important, even if it didn't have the same sort of outcomes that they predicted. Um, One of the things I'm really excited about is the RX Kids findings that I think are really promising. This is the program that offers every baby born in, or every woman pregnant in Flint, Michigan, $1,500 and then $500 every month until her baby turns one. And they're expanding this to 7 additional communities in Flint. They're using TANF dollars as a basis for a lot of this. Um, and that's an example of when they did a population level study. So we can't do a randomized control trial and a randomized control trial. It's also a different time period and so forth. I'm sorry, the randomized control trial was the baby's first years that you were mentioning. Those will often see different results. Now, the truth is, randomized control trials often see better results than what we see at scale because of this voltage effect that, the more that kind of it gets to a larger and larger population, the kind of energy behind it, the rigor, the attention to fidelity starts to evaporate quite a bit. So it's interesting that we saw population level estimates different than RCTs. And my colleague Greg Duncan, who was very much involved with babies' first years, may not trust the population level estimates as much as we'd like to. But we certainly do have this come up all the time where different studies will look at a similar problem and come up with different outcomes, different findings on the same outcome. And we spent a lot of time discussing the rigor, the relevancy, the recency of the studies, what we think we can say, how nuanced we need to be. It's very hard as a researcher to say, yep, this works. But we know that states need that sort of guidance. And if they're going to start anywhere, they may as well start with things that have some evidence of effectiveness. But so I don't know if I answered your question, but yes, we think that the cash transfer programs have a lot of promise and are not the silver bullet.
I think we are just right at time. Thank you again, Cynthia, for just an outstanding presentation today. Thank you all so much for joining us. Please feel free to email and or share questions that you have that are unanswered. The Prenatal-to-3 Policy Center team is here today, and I know that there will be opportunities to be responsive to those questions over email. We will also share out the resources, the incredible resources shared today through a post-meeting email as well. And we look forward to remaining connected with you all. Thank you so much for your time this Tuesday afternoon. Hope everyone is feeling motivated and encouraged. Thank you. Have a great
Thank
afternoon.
you. Bye-bye.
Thank you so much.